Okay, welcome to part 2 of chapter 13. Part 2 is mainly going to deal with specific body systems and the medications that affect or that we give to affect those specific body systems. This is by no stretch of the imagination going to be a comprehensive discussion over every possible medication that's going to affect a given body system. It's more of kind of an introductory welcome to a way that we can kind of put some tools in your theoretical toolbox so that you're able to have a little better understanding of how medications affect particular body systems. So that's our goal. That's kind of what we're hoping to accomplish. But you'll notice that I'm not going to spend a whole lot of time really just, tearing apart each body system and how each one of these medications work. This is really kind of a superficial understanding of this. That way you can continue to build on this as we progress through the paramedic program. So realize this is introductory. We're going to talk a lot more about these medications, and we're going to get more in depth into these illnesses and those types of things that affect these body systems. So first system that we're going to look at are drugs that act on the sympathetic nervous system. Of course, we're going to start off our discussion in part 2 with probably the most complicated discussion that we can have. And it has to do with the sympathetic, parasympathetic nervous system, that division of the nervous system. So think back to the nervous system, sympathetic, parasympathetic. Remember, sympathetic's fight or flight, parasympathetic is rest and digest. So we're mainly right now, we're talking about drugs that affect the sympathetic nervous system. But remember, these two, the sympathetic, parasympathetic, are always trying to stay in balance. So where we affect one, we ultimately wind up affecting the other. Therefore, we can't really have a discussion about medications that affect the sympathetic nervous system without at least mentioning the parasympathetic nervous system. So we're going to talk a little bit about the parasympathetic nervous system, and there's going to be a couple of slides and a couple of things that's not necessarily in your book on this particular section, but I added them in here not as testing material, but just as material that'll hopefully help clarify things a little bit, okay? So remember, we've got these receptor sites that exist in the form of proteins that are connected to cells throughout our body. Remember, these are activated by chemicals, acetylcholine, epinephrine, norepinephrine, all of those types of things. Remember these receptors that are activated by that. Remember the cholinergic, or the sympathetic side that actually is affected, the neurotransmitters that affect the sympathetic side are the epinephrine, norepinephrine, and those types of drugs. Parasympathetic, we mainly see acetylcholine, though acetylcholine can act a little bit on both sides, remember, but when we're talking about sympathetic and parasympathetic, typically we're talking about epi, norepi, those kinds of drugs, okay? And those are acting on those receptors in this sympathetic side of the nervous system. So really we're talking about the sympathetic side of the nervous system right now. And one of the things, those of you guys that took my anatomy and physiology class, we didn't talk about beta 1, beta 2 receptors, alpha and beta receptors that are present in the sympathetic nervous system. And basically what these receptors are, they're location specific. We have alpha and beta receptors. They're basically receptors on organs that when the right transmitter plugs into them, it causes that organ to respond to that stimulus, okay? So when we have the right neurotransmitter that plugs into them, it causes that particular organ to react. Beta 1 receptors are only in cardiac muscles. Beta 2 receptors are only in lungs, okay? And then we have alpha receptors, and it says that there's some beta receptors in the arteries. There's some there, but mainly we have alpha receptors and in the arteries, and there's some alpha receptors in the lungs, but they're not really ones that we'll spend a whole lot of time or really any time really talking about. So, all right, so if we break these two down, two groups of beta sympathetic agents are beta 1 and beta 2. These are on the sympathetic side. Beta 1 mainly affects the heart, blood vessels, and the kidneys. Beta 2 mainly affects the lungs and the kidneys. So if we give a medication and we want that medication to act upon the heart in a sympathetic manner, typically that's referred to as a beta 1 drug. Epinephrine, when we give it IV, is a beta 1 drug. Interestingly enough, if we give epinephrine by inhaler or by nebulizer, its actions are going to primarily be within the lungs. So, and then we have the alpha sympathetic agents. There's a typo right there in group 2. There's 2 alpha sympathetic agents. We have alpha 1 and alpha 2. And alpha 1 mainly the vessels, a little bit at the heart, kidney, a little bit of lung. Alpha 2 and still in the vessels, kidney, a little bit of lung. But when we look at these, when we think, what I want you guys to walk away from this with, beta 1, I want you to think heart. If we give a beta 1 agonist, remember agonist is going to make it happen. Beta 1 agonist, we're looking at an effect on the heart. That's what we're wanting from beta 1. Beta 2 agonist, lungs. That's what we're looking for there. When we get down to the alpha side, we really don't make a lot of distinction between alpha 1 and alpha 2. We think of alpha 1, alpha 2 as one group of alphas, and what we are trying to affect is the blood vessels. So here's how that works. So we're trying to stimulate the heart to beat, pump faster or pump harder. That's beta 1. So we give some epinephrine to a patient in cardiac arrest. That's going to be a beta 1 response that we're looking for. If we have a patient that's having trouble breathing, their lungs are they're bronchoconstricted and that kind of stuff, and we want to give them albuterol or Atrovent, mainly albuterol. Albuterol is a beta 2 agonist, and it's going to act in the lungs. It's going to cause some some bronchodilation. So and then alpha, if we give somebody dopamine, that's what we're looking for, is the alpha response in the dopamine to cause vasoconstriction. All of these are sympathetic responses. Okay? Alpha, beta, all sympathetic responses. Okay? So that's the way that we kind of need to think of these. I know it's something new, but it's really, really not all that complicated. And hopefully I haven't overcomplicated it or made it more difficult to understand. I can do that sometimes. But think of alpha and beta are both sympathetic responses. Alpha is all vessels, and we're looking at vasoconstriction. Beta 1 is heart. Beta 2 is lungs. But remember, it does affect some other things other than those areas. There is some receptors in some other areas other than just those areas. Okay, here's kind of a chart that breaks that down a little bit more. It gives a little bit more specific information on, where the alphas and betas affect. But remember, these are all sympathetic nervous system reactions. We're causing a stimulation of the sympathetic nervous system. We just break it down further into alpha and beta, and then further down into alpha 1, 2, beta 1, 2. This way we can look at it more specifically in the specific area or the specific receptors that particular drug or that particular medication is going to target. So when we look at a medication and we see that it's a beta 1 agonist, or a beta 1 antagonist or that kind of thing, we can see that it's either going to stimulate the heart or it's going to slow down the heart. Or if it's a alpha 1 and 2 agonist, like dopamine is. Dopamine's got both. And as you progress up the scale of giving more and more dopamine, it goes from more alpha 1 to more alpha 2, and it kind of changes the effects and the way that it works. So that's kind of a chart I threw in there so it might be helpful to you guys to kind of have a little bit more of a frame of reference. Okay? So the thing is when we look at this, it has to be specific in order to target those organs. On the heart, there's no alpha receptors, so that alpha drug's not going to affect the heart. There is some in the lungs, not a whole lot, might cause a little bronchoconstriction, but not on a vast scale. But on the arteries, it's going to cause some significant vasoconstriction. And of course, that's going to be dose dependent. The more of those receptors that we call into play, the more vasoconstriction is actually going to happen. So, when we give a drug that stimulates or it mimics the effects of the sympathetic nervous system, we call it a sympathomimetic, so, because it mimics what a sympathetic nervous system response would be. So these are drugs that have an alpha or beta sympathetic properties, and we call it a sympathomimetic. So epinephrine would be considered a sympathomimetic. Dopamine would be considered a sympathomimetic. I went ahead and threw that there are such things as parasympathomimetic drugs, and these drugs are drugs that affect the parasympathetic properties. There's also something called sympatholytics, meaning drugs that block sympathetic properties. So there are some drugs that's going to block those sympathetic properties. And there's also parasympatholytics, drugs that block those parasympathetic properties on the other side. So you can see this can get very confusing and very complicated, but if we just think about it, if you think about it in terms of medical terminology and you look at it and you say sympathomimetic, then we're talking about the sympathetic nervous system and something that mimics the sympathetic nervous system. So that's going to be something that a drug that we would expect to have sympathetic nervous system responses. Now, epinephrine, depending on where we give it, will determine the extent of how much will it actually affect the heart versus the lungs versus the vessels. So if we give it nebulized to the lungs, it's going to affect the lungs more. It's still going to affect the heart. It's pretty strongly heart effective. If we give it in the blood vessels, it's going to affect the heart mainly, but it'll affect other things. If we give it below the skin, sub-Q, it's going to primarily affect the vessels, a little bit and it's going to affect the lungs too, but it's not going to affect the heart as mightily or as greatly as if we gave it IV. So that's how you can kind of think of these drugs: parasympathomimetics, sympatholytics, parasympatholytics. Lytics means lytic means to lyse or to cut off or to stop. So that's kind of a breakdown of where those drugs work. So we can see here there's a sympatholytic in the way, or a sympathetic blocker in the way. We got this little mustache guy. He's kind of blocking that site from the beta stimulator, so he's a beta blocker. He's actually blocking that. We actually have medications, I'm sure you've probably heard of them, that are beta blockers. So their job is to block mainly beta 1. The beta 2 is not something that we typically want to block. It's not necessarily a good thing. But we do have some beta blockers that affect the heart, and their goal is to slow down the heart's rate and its contractile force. And these can be called a sympatholytic or a sympathetic sympathetic blocker. So this particular one is a beta blocker because it's blocking the beta side of things. And then there's beta adrenergic blockers that prevent beta agents from exerting their full effects. And they can affect all three areas. Let me back up just a minute. Atropine, which we'll talk about a little bit more later, atropine can actually be considered a sympathomimetic or a parasympatholytic. Either way, a lot of times it's looked at either way. Atropine, actually part of its effect is to block the parasympathetic side more so than to stimulate the sympathetic side. So it blocks the parasympathetic response, allowing the sympathetic nervous system to take over. Increased heart rate, all of those things, dry mouth, pupils and all that stuff. So those are the things that we would expect to see from atropine, which atropine's a drug we'll talk about a little bit later, but it's still part of that, how its effect is kind of on the nervous system a little bit, okay? Medications that we use in airway management, and I added up there not nebulized medications. This here is the sedative hypnotic agent such as etomidate. These work is a very profound sedative. It works very well. Minimal effect on blood pressure, works in 30 to 60 seconds, lasts only about 5 minutes. And it has a maximum of 1 dose. This is one of the drugs that is commonly used for intubating patients. Ketamine, it's another popular one. We're seeing more and more carried in the pre-hospital setting. Profound dissociation and anesthesia. Can maintain blood pressure and heart rate. Raises intracranial pressure though, so that's going to be a concern if we've got somebody with a possible head injury. And it can cause some degree of bronchospasms. So if we've got a patient that is having some bronchospasm issues already, or may have a head injury, this may not be our drug of choice. We may have to look at something else. Benzodiazepines are our Valium and Valium derivatives. They're potent, good for anti-seizures, sedative, and has some really good sedative properties. Sometimes high doses are required for adequate sedation, so sometimes we'll use Ativan, Versed, those types of things in those instances that have a higher potency. They can be used to treat active seizures. Valium actually works very well for that. It does have a Class D pregnancy precaution. It can be harmful to the fetus, so we have to be careful with that. Flumazenil is another it's a benzodiazepine antagonist. It's competitive. It is not being used so much anymore because there are some risks that kind of outweigh the benefits in most of the situations where we might use it. So it's kind of fallen out of favor. There's some other paralytic agents that provide muscle relaxation. Most of these are designed to be used for airway placement. Also helps with patients that are on ventilators to not cause issues with ventilatory issues. These bind with nicotinic receptor sites, and they antagonize the acetylcholine, which normally causes muscle contractions when it's released. So this actually works on the somatic side of things, as opposed to the nervous system side, or the central nervous system side. So this actually works on the somatic side of things, and where it works with the nicotinic receptors on the muscles to block the effects of acetylcholine, so muscle contractions can't happen. And we see an example of that here, where these acetylcholine receptors are taken up with this paralytic agent that doesn't allow those muscles to contract. Acetylcholine is another one. It's a competitive depolarizing paralytic agent. Has a fast onset, brief duration. That's why it's really good in EMS. The problem is it can cause some hyperkalemia, bradycardia, interocular pressures, malignant hypothermia or hyperthermia. Why are these important? Well, if you have somebody that is, predisposed to hyperkalemia, such as someone that stopped taking their Lasix but is still taking their potassium, or someone that's taken a beta blocker, a bradycardia might be an issue. If they have glaucoma, interocular pressure might be an issue. If they're a little hyperthermic already because of the environment that they're in or whatever, some environmental factor, that could be a problem. So those are all things that we're going to have to consider and be prepared for in the event that we use this as a paralytic for taking care of our patients. There's some non-depolarizing paralytic agents, such as the ones that compete with acetylcholine at the nicotinic receptors like we talked about. There's rocuronium, which often is called ROC, rapid onset, short duration, vancuronium, long onset. It's available as a powder for reconstitution. These are pretty commonly used in flight service. We see these used a lot in flight service. They are starting to be used a little bit, or have been used a little bit in ground transports. These the other airway medications, when upper airway edema is present, the following must be used: corticosteroids, vasoconstrictors, bronchodilators, those types of things need to be used when we have upper airway issues, especially when there's edema present. Corticosteroids is one of those things that we commonly use with asthmatics. The thing is when an asthmatic has an asthma attack, usually we can get them through the first insult of that. The problem comes in when about 8 hours later, when the edema sets in, and that's when the corticosteroid's really helpful in those situations. Oftentimes asthmatics, they manage to be able to take care of the initial asthma attack on their own at first, and then it kind of gets away from them. 8 hours later, they're in a bad way. They're calling an ambulance. Beta agonist medications are the primary treatment for acute bronchospasms. So those patients that have respiratory or breathing issues, we're going to use a beta agonist. So we're going to use a beta 2 stimulator. These cause muscle relaxations and bronchodilation. They target only beta 2 receptors. Are the selective ones. The non-selective ones are going to hit beta 1 and beta 2. Atropine, actually, they used to nebulize atropine, and it was pretty non-selective. The selective ones now that we're using work really well, and they have little effect on the heart. One of the things that you're going to see whenever you're making your drug cards is you're going to see that that these one of the contraindications or the precautions or warnings about using shoot, I can't think of the name of it. Albuterol is rapid heart rate, fast heart rate. You don't want to use it with a fast heart rate. So that's one of the precautions, or one of the times when they say you can't use it. However, a lot of times if they're hypoxic, that's probably what's causing their rapid heart rate, as opposed to not giving it, which is going to cause a lot of problems. Usually the amount of heart rate increase that is caused by given Atrovent is marginal. And usually not a huge problem. I've never experienced a problem with the heart rate increase in giving that. Of course, albuterol is one of those selective 2 beta agonists, but it can affect heart rate to a small degree. It's usually nebulized or in a metered dose inhaler. There's levobuterol, which is similar to albuterol. It has fewer beta 1 effects. And then there's terbutaline and epinephrine, which start to kind of get out there and in the beta 1 realm a little bit more than what we want to. Mucokinetic and bronchodilator medications. Entropium bromide is one of those dual purpose. It helps antagonize mesocarcinic receptors, reduces mucus production, causes bronchodilation, and decreased mucus in the upper and lower airways, which is beneficial when somebody's trying to breathe, is to reduce that mucus production. Corticosteroids reduce airway inflammation and improve oxygenation and ventilation. They have immunosuppressant properties and many contraindications and adverse effects to these corticosteroids, especially for long-term use. Now, like I said, I'm just kind of going through these. I'm whizzing through them. I'm kind of hitting the high points. I'm not going to talk about these in detail about how their specific actions work. That would take far, far too long to do. And it would be a very, very, very long and boring, tedious lecture. What you need to do with these is, if they're one of these that it's on your drug list, what you need to do is look those up, see what its mechanism of action is, study that drug, understand it, figure out how it works, and that way you have a better understanding of it. I'm just kind of hitting the high points for these. Still respiratory management. There's some leukotriene receptor antagonists. These aren't used real commonly. These aren't used commonly in the pre-hospital setting, but they're used on a long-term basis. We'll see these as a Singulair is a very, very common one. And I'm not really familiar with this one, Accolate. I've not heard about a whole lot about that one before. Antidysrhythmic medications, when we get into the cardiovascular system, target cells within the heart. What we do is we try to target those cells within the heart to resolve the dysrhythmia, or at least suppress the irritable site, the ectopic focal site. There's a Vaughan Williams classification for groups of medication, and it puts them in 4 classes. And here they are. Actually, that says 4. This is 5. Of course, they've got, that's actually the 5 phases, my bad. So this Vaughan Williams classification puts those medications, the antidysrhythmic medications, into 4 classifications. Don't worry about what those 4 classifications are, But antidysrhythmic medications is a good category, general category to know in order to plug some of your medications in. The way that these work, if we remember the 5 phases of cardiac cell activity, remember the cardiac cells are at rest, then we have a rapid influx of sodium ions. As that sodium ion decreases, potassium begins to exit the cell, calcium starts to move in, then potassium starts to exit, a little more potassium goes out, calcium movement ceases, and then potassium outflow continues, and then the sodium potassium pumps kick in and they try to reset everything back to where that it's supposed to be. So that's the 4 phases of cardiac cell activity. At any one of these places, if we give a medication that is a blocker, that blocks some of these channels, then we can affect that. I will tell you this, we don't give potassium blockers, we just don't mess with them. But we do sodium blockers and calcium blockers in varying degrees for varying purposes to affect those channels within the heart cells. That way we can affect what's going on in there. We either slow the rate down. Primarily calcium is what we use to slow the rate down. Sodium is what we use the sodium channel to affect irritability within the heart for PVCs and those kinds of things, and VFib and VTAC is what we use. A big sodium channel blocker is lidocaine. Another one that blocks sodium and a few others is, they kind of call it the dirty drug, is amiodarone. Amiodarone actually hits several of those channels, and amiodarone is actually a drug that is given routinely for a daily dose medication to patients as well to control heart rate and contractile force and those different kinds of things because it is effective at doing that. The classes of these medications, here's the class 1, which is antidysrhythmic medications. Basically, they slow the movement of sodium in cardiac cells. Procainamide is one of them. Lidocaine blocks them. Procainamide slows them. That kind of those are ones that work on the sodium channels. That's a class 1. Class 2 are beta adrenergic blocking agents. They inhibit catecholamine activation of beta receptor sites. So class 2s work on the beta receptor sites. May be capable of beta 1 selectivity at the therapeutic doses. But can cause some massive conduction abnormalities when given with calcium channel blockers. So calcium and beta blockers should not be mixed together because they can cause some really, really big problems. Metoprolol at low pressure is the example that they use for that, but it's not the only one. Reduces heart rate and ischemia. Class 3 are those medications that are used during the prolonged absolute refractory period. These treat the atrial and ventricular tachycardias. Amiodarone is one of those. Amiodarone will also treat in emergency situations, VFib, VTAC, and those as well. But on a long-term basis, they treat Wolff-Parkinson's-White. It could cause some adverse problems. There's also Sotalol, which is taken orally for ventricular and atrial dysrhythmias. The last category, class 4, is that calcium channel blockers. Has a variety of uses. A lot of what they're using it for nowadays is reducing blood pressure, but it is used to control heart rate. And it also is used in the treatment of cardiomyopathy. It displaces calcium at certain receptor sites or enters smooth muscle cells in place of calcium. Decreases the automaticity of ectopic foci and velocity of cardiac contractions. So it kind of eases out the cardiac contractions and lowers blood pressure too. Depending on the drug, the medication that you're given, and what it's supposed to target. There's a lot of different types of calcium channel blockers. The big one is verapamil, and then ditilazim or cardiazim. They control heart rate with atrial fib and atrial flutter. Administered IV over 2 minutes, require continuous EKG monitoring, frequent blood pressure monitoring. The antidote for this, of course, is calcium chloride. If you give somebody too much verapamil or cardiazim, of course, we're not giving it in the field so much anymore like we used to. We used to carry it all the time on the ambulance. It's not real common that we carry it on the ambulance anymore, but it is important that you're familiar with verapamil and ditilazim because they're still both commonly prescribed in the field. There's also Norvasc is one of them that they prescribe for blood pressure. That is a calcium channel blocker. So there's a lot of options out there when it comes to that stuff. Adenosine is actually in an unnamed class. It decreases cardiac conduction velocity and prolongs the effective refractory period. Basically, it produces a pause in cardiac activity. It is a rapid onset and a brief duration. It's administered through a large bore IV. It is actually naturally occurring in the body, so it is not something that someone would be allergic to. This is one that we have SVT or something like that we need to treat, and we'll give them this medication to treat that. And it's usually effective, but sometimes it's not. Sometimes we have to cardiovert them. Alpha adrenergic receptor antagonists, they prevent endogenous catecholamines from reaching alpha receptors, and they do this in order to lower the blood pressure. They decrease systemic vascular resistance. They're for patients with hypertension, enlarged prostate, or glaucoma. Of those, we have clonidine, or catapress. It is an alpha-2 receptor agonist. And then there's regantine, which is subcutaneously injected, and labetalol, which is an alpha-1, beta-1, and beta-2 agonist properties. So these aren't used as much as they used to use them. These were some of the early medications. They're still used some, so don't be surprised when you see them. Not unusual to see them. There's some cardiologists out there that are not old school cardiologists. They're new school cardiologists that are reaching back into their bag of tricks, and they're using some of these older medications in different combinations to find the results that they're looking for. So don't be surprised when you see those. ACE inhibitors, angiotensin converting enzyme inhibitors, they alter the function of the renin angiotensin system. What they do is they cause the blood pressure and cardiac afterload to decrease by preventing angiotensin 1 from converting to angiotensin 2. Angiotensin 2 in the heart muscle and in the blood vessels causes vasoconstriction. So if they reduce the amount of angiotensin 1 that's converted to angiotensin 2, they can keep the blood vessels from constricting, and they can decrease cardiac afterload. So it's used to treat primarily hypertension, but they do treat cardiomyopathy too, and some CHF. Some patients may have a chronic dry cough, a little tickly cough that's kind of annoying, or they can experience sudden life-threatening angioedema without any, just kind of out of the blue. Anticholinergic medications, they oppose acetylcholine. Remember where acetylcholine worked, right? This acetylcholine, remember, is produced by the parasympathetic nervous system, also called parasympatholytics. So atropine is a muscarinic receptor agonist. It is related to the concentration of at receptor sites compared with acetylcholine, so you have to have enough atropine at the receptor sites compared to how much acetylcholine there is. It treats bradycardia when vagal stimulation of muscarinic 2 receptors is suspected. So atropine is one of those anticholinergic medications that opposes acetylcholine, and it's also called a parasympatholytic. So atropine causes a sympathetic nervous system response by blocking the parasympathetic nervous system. Okay, so that's how atropine works. Sometimes it's used before airway manipulation because sometimes intubating patients can cause some bradycardia. I would recommend not just prophylactically giving somebody atropine unless that there is some predisposition to them bradycardying whenever they're intubated. It is also a life-saving antidote for acetylcholinesterase inhibitor toxicity, which acetylcholinesterase inhibitor is used in household poisons and nerve agents. So that's that antidote for those. Catecholamines and sympathomimetics, I'm trying to make new words. Catecholamines stimulate receptor sites in the sympathetic nervous system. They contain this catechol group and a monoamine oxidase group. They're rapidly metabolized, so they have a brief duration and a brief action when they're used. Catecholamines, an example of those is amphetamines, albuterol, cocaine are some longer duration ones, but sympathio, these are those are synthetic ones. I'm thinking that here's where they're talking about some epinephrine. Epinephrine is a catecholamine that stimulates alpha, beta 1, and beta 2 receptor sites. IV, IO, IM, sub-Q, endotracheally if you have no choice, and nebulizer. Can dramatically increase cardiac workload and myocardial oxygen demand. So we have to be cautious whenever we're giving epinephrine, and we need to make sure that we're giving it for the right reasons. Most people don't realize the main purpose for why we give epinephrine in cardiac arrest. They always think that it is to stimulate the heart, though that is part of it. One of the key reasons why we give epinephrine in cardiac arrest is to cause vasoconstriction, to affect the alpha sites, to cause some vasoconstriction, to cause those blood vessels to constrict, so it increases blood pressure and improves the CPR. Problem is epinephrine, if you've got a heart that's basically blown up because, it can't work no more, we're going to stimulate it to work harder when it can't work anyway. So it's just not possible. It's like a blown up engine in a race car. You keep pouring more gas in it, it's not going to make it go. It's just not. It's gone. Norepinephrine, also called Levophed, is a catecholamine that stimulates beta 1 and alpha receptor sites. It's given by continuous IV, titrated according to patient response, and it can cause some tissue necrosis if you're not careful with it. Dopamine is another one of those drugs that we use. Primary medication for hypotension, refractory to volume resuscitation. Dobutamine, synthetically manufactured catecholamine, similar to dopamine. Not usually used a lot in pre-hospital settings, but don't be surprised if you have to take a critical transport that's on dobutamine. I've taken a few of them. Primacor, similar to dobutamine. I've never transported with it. Can be given orally or IV. Increase cardiac contractility, cause dilation of systemic arteries and veins, improves cardiac output. Neosynephrine. It's a synthetic, almost pure alpha agonist medication. A potent vasoconstrictor. Longer duration than catecholamines, may cause reflex tachycardia, and it's extravasitation is a major concern. What this is it's the sinus medication, that causes vasoconstriction. That vasoconstriction is to reduce congestion is mainly what it's for. However, this works very, very well for nosebleeds that you can't get to stop. Sometimes they'll put tons of this stuff up in there, just squirting and squirting and squirting and squirting and squirting and squirting, trying to get that vasoconstriction to help to cause the bleeding to stop, to cause the nosebleed to stop. DIG preparations. DIG actually increases the strength of cardiac contractions, improves cardiac output, slows conduction through the AV junction, slows the heart rate, but it may produce a wide variety of adverse reactions. So DIG is not something that they use routinely. It's also one of those that they have to monitor really closely, the levels, so somebody doesn't become toxic to that. There are some medications that are direct vasodilator medications that we use for uncontrolled hypertension, CHF, myocardial infarction, cardiac ischemia, cardiogenic shock. So there's a lot of other medications that are possible in our arsenal. Nitro is one of them. Dilates coronary veins and arteries, but it can dilate other arteries in the body. The idea is to dilate those arteries to get better blood flow. The dosage is IV, 5 micrograms per minute, can be up to 200 micrograms. Remember when I told you the sublingual dose was 0.04 milligrams? That's why this dose is IV is even it's much smaller than that on a per minute basis. So what we're doing under the tongue, it takes a little bit more to get the effect that we want. Nitro can cause some tolerance. The tablets that a person has can degrade. They don't like sunlight. They need to be kept in their sunproof vial or something that doesn't allow any sunlight in. They'll start to turn yellow, get real flaky and weird looking when they go bad. So when somebody says before you get there, they say, well, I took my nitro, but it didn't work, say, let me see your nitro. And you get them out and look at them and see if they're maybe not any good. Should not be taken by patients in FISO 5 inhibitor for, So if they're taking an erectile dysfunction medication, they shouldn't take this, shouldn't take nitro because it can be dangerous. It can cause their blood pressure to bottom out. Sodium nitroprusside, it's an IV vasodilator. It affects the smooth muscles of veins and arteries. We set at an IV infusion and maintain the optimal blood pressure. Once the infusion stops, it will wear off pretty quickly. And it's not unusual to transport somebody from point A to point B with the sodium nitroprusside drip. Transported a few of them. Apresyline is used in hypertensive emergencies for pulmonary hypertension in pregnant patients with eclampsia. It dilates arterioles, lowering pulmonary and systemic vascular resistance. It's administered over at least 1 minute and repeated up to every 20 to 30 minutes. Once again, this is probably not something you're going to carry on your ambulance, but it is possible that a doc may go, I'm going to send you with this. We've been giving them this, and I'm sending you with it. So you need to be ready to look these things up and get familiar with them. Flolan, potent vasodilator, inhibits platelet aggregation, so it stops blood clotting. A continuous infusion for some patients, not typically administered for the first time in the pre-hospital setting. And then we've got some diuretic medications. They're administered to correct volume overloads, manage CHF, improve respiratory and pulmonary edema patients, maybe even preserve some kidney function. Lasix is the main one of this. It's a loop diuretic, oftentimes used to treat hypertension, but it can also be used to treat generalized edema. Need to be careful when we're administering this for hemodynamic instability and electrolyte disturbances because, like I said, where the water goes, the electrolytes go. Lasix is going to take them with them. Mannitol is one of the other ones. It's an osmotic diuretic, so it works more at the cellular level than in the loop of Henle in the kidneys like Lasix does. And it's used to help to decrease intracranial pressure, like I talked about earlier. And then there's some other antihypertensive agents to treat high blood pressure, either diuretics or beta blockers or a combination of those. Some patients that are taking some of these may have some symptoms of hypotension, such as orthostatic vital signs. So those are some of the things that we'd have to watch out for. Like I say, when you get into history taking, assessment, and all that kind of stuff, you're going to find that we harp on you about assessment, finding out the information, being a detective, asking the right questions. You just got to make sure that you're checking everything before you're jumping into your treatments. We do administer blood products from time to time. Rarely are we the ones that start the blood. But sometimes we're continuing it. Of course, blood constitutes about 7 to 8% of our weight. Sometimes we have to transport somebody with some blood hanging, and sometimes we even have to switch it over. Rarely are we hanging blood in the field, but sometimes it does happen. These blood components are usually type specific, A, B, O types. They're usually cross-matched to make sure there's not a reaction, but sometimes they will give somebody just packed O negative red blood cells, and it's in the hopes that they don't have a reaction because O negative is a universal donor. They still can have a reaction, but it's less likely, at least until they can get someone typed and cross-matched. Of course, we got to monitor them carefully whenever they're on blood products. We got to watch them very, very close because things can happen quickly. Monitor their pulse rate, blood pressure, respiratory. So we need to monitor the urine color changes or anything like that. Packed red blood cells are administered to correct anemia. Of course, the rate that they're given should be proportional to the rate of the loss. There's about 225 to 250 milliliters of concentrated red blood cells. If we give it too fast, they can get fluid overload, so we have to administer it slowly and carefully. So when you leave the hospital, if they've got packed red blood cells hanging and they say, we want you running them at this rate, run them at that rate. Don't be a hero and try to think you got to run them in really, really fast. But they're usually over no more than 4 hours per unit. A unit usually contain a citrate-based preservative to keep the blood fresh and okay, so it can hang for that long. But there may be some hypokalemia or hyperkalemia. Hypocalcemia or hyperkalemia may develop because of that. Frozen plasma is also can also be used to treat some blood clotting issues, but it also needs to be typed and crossed, but they don't have to worry about the RH. 225 to 250 mils per unit. They require defrosting before administration. Other blood products that contain a concentrated assortment of blood clotting factors without the additional volume present in the fresh frozen plasma sometimes is used as well. Sometimes they just give them straight up platelets, but you got to watch blood type and RH factors when you do that. All right? There are some medications that alter blood performance. Some blood platelets combined with coagulation chemicals to terminate bleeding. When clotting occurs, a thrombosis is created. Medications can alter the ability of that thrombosis to form. This tranexamic acid promotes blood clotting and reduces mortality in trauma patients with severe bleeding. Recommended dose is 1 gram in an IV infusion over 10 minutes. Anticoagulant medications impair the function of clotting or coagulation chemicals in the bloodstream. Some of them even enhance the function of the substances that are already present in the bloodstream to inhibit clot formation. Heparin is an example of that, or Lovenox is another example. Oftentimes when somebody's having an MI, they'll put them on heparin to keep them from forming more clots in that area, because what's happened is there's probably a narrowing inside one of their coronary arteries that's causing some turbulent flow, which is causing some aggregation of platelets in that particular area and starting to form clots. What they'll do is they'll give them some heparin or some Lovenox. Usually Lovenox is just a shot, and what that'll do is it'll help diminish or decrease the likelihood of clot formation, which is helpful. Let's see. This first one here, Arixtra, is used to prevent deep vein thrombosis, which is not real common, but Coumadin or warfarin is very, very common. Used to be kind of the only thing that we could use for post stent placement and all that kind of stuff. But the problem is they're at risk of bleeding if those levels aren't maintained, or if they get in a traumatic incident or some other type of hemorrhage, they can bleed out. So there's some concerns there that have to be watched out for. Some antiplatelet. There's actually some other ones. There's a Plavix down here, and there's some new ones. But there's some antiplatelet medications prevent thrombus formation. Aspirin, Plavix. And some others. Fibrinolytics dissolve clots in arteries and veins. This used to be the only way that we could save somebody that was having an MI was to dissolve this clot. Sometimes it still is absolutely essential to get the clot dissolved. The problem is they dissolve that clot using this, then there's a problem with them being able to form a clot. So it makes it more difficult for them to be able to go in and get a stent put in. Once they've given a fibrolytic. So there's kind of a catch-22. Well, if I give the fibrolytic, They may not be able to get the heart cath in very soon. It might be a couple of days or 3 days. Or if I wait, it may cause too much heart muscle damage. So they have to make a decision on whether or not to give a fibrinolytic to bust a clot and then send them up somewhere to get a heart cath in. So it's a decision time, but it's not a decision that you need to worry about. You just need to make sure that you transport them to the place that's going to take care of them. Okay? They can cause some life-threatening hemorrhage. So you want to avoid multiple IV attempts and unnecessary trauma. And prolonged pre-hospital time may preclude administration of this. Narcotics. We've talked about narcotics some. They're used as pain relief or analgesics in the pre-hospital setting. They stimulate those opioid receptors to relieve pain. They can cause some tolerance, cross tolerances, and of course addictions. They can cause profound sedation, respiratory depression, apnea when used in excessive doses. So we have to be cautious of that too. Morphine, fentanyl are pretty common for those. Morphine we used to use a lot because it decreased myocardial O2 demand. Fentanyl actually seems to have some better properties to it because it doesn't have a tendency to lower blood pressure like morphine can. Morphine can do that. Narcan is used to reverse the effects of that, but it is dose dependent. Depending on how much narcotic or opioid they have in them, you're going to have to keep continually giving Narcan until that starts to wear off, so it may be a long-term deal. Dilantin is another one, and Sebrex, they prevent seizures. It's an opioid antagonist. And may be used on a long-term basis. Can be used as an IV infusion. Fewer adverse effects. Dilantin's not as popular as it used to be, but they still do use it. It still gets used quite a bit for seizures. GI system, there's histamine 2 receptor agonist that decrease the acid secretion in the stomach. That is Pepcid. Pepcid is a histamine 2 blocker. It prevents histamine from stimulating receptor sites in the parietal cells of the stomach. Zantac, Tagamet, Pepcid, they're all histamine 2 blockers. That was the early ones that they come out with. Used to be Tums or Rolaids, and then we come out with the histamine 2 blockers, and now we have some proton pump inhibitors that work really well too. Antiemetic medications, anti-vomiting medications, nausea and vomiting, promethazine or phenergan or compazine. These can be given orally or by IV. There are some adverse effects that are related to IV administration, such as with phenergan. If you give them too much, it can cause what's called dystonia or a dystonic reaction that looks like they're posturing or seizing. Oddly enough, the treatment for dystonia is Benadryl. We give them 25 to 50 milligrams of Benadryl. It seems to take care of the dystonia or the dystonic reaction. They don't really understand how that is or why that works. It just does. There's also Reglan that increases GI motility, and it's available orally by slow IV or IV infusion. The interesting thing about Reglan was originally developed as a antidepressant medication, and what it was designed to do was to keep more dopamine in the brain. It didn't work, but what they found was it increased GI motility by increasing the receptors in the gut. So then they started using it for that. So interesting how they start to use things. It was developed for one thing at once, and now it's used for something completely different. Sandostatin is a synthetic version of somatostatin, decreases secretion of insulin, glucagons, growth hormones, and various other chemicals. Has many potential uses. Not usually given in the pre-hospital setting. Tylenol, acetaminophen. It's an antipyretic, meaning it helps with fevers, and a mild analgesic property, so it helps with a little bit of pain. Available as a tablet, capsule, liquid, rectal suppository. Don't give it orally with patients with a high risk of seizures. It rarely has adverse effects unless you give them too much, and then it can cause some liver problems. And then there's some calcium preparations under miscellaneous medications used in the pre-hospital setting. We use it as calcium, like calcium chloride, calcium gluconate, as an antidote for calcium channel blocker overdoses. Treatment of magnesium sulfate toxicity, which is usually calcium gluconate. Prevention of dysrhythmias, calcium repletion in patients with hypokalemia, calcium restoration from hydrofluoric acid, and prevention of hypotension. IV calcium is available, calcium chloride, calcium gluconate. Like I said, usually it's calcium chloride we use for calcium channel blockers and calcium gluconate that we use for mag sulfate overdoses. Monitor IV sites to avoid extravasation and avoid sub-Q and IM administrations. Dextrose, used for known presumptive hypoglycemia. Large bore IV catheter, 25 grams of a 50% solution for a total volume of 50 mils. This is also very prone to cause tissue damage if you have a bad IV. Benadryl, used in a variety of clinical situations, treat allergic reactions, mild sedative, mild antitussive properties that it has. It's a histamine 1 receptor antagonist, typically administered IV or IM. It does have some adverse effects such as sedation and some palpitations, sometimes a little anxiety. Glucagon is a naturally occurring peptide manufactured commercially. Treat hypoglycemia to provide, and it may provide increased heart rate and contractility. Calcium channel blocker overdoses, it can treat severe calcium channel blocker overdoses, or treat a patient who has a foreign body lodged in their esophagus. Don't even ask me how that works, but apparently it does. Ketorolac may be used for an alternative to adjunct to opioid analgesic medications. It's an NSAID that inhibits prostaglandin synthesis, typically administered IV or IM. Can't be given to patients that have a history or are susceptible to GI bleeds. Mag sulfate, IV electrolyte, emergent treatment of ventricular dysrhythmias, such as torsades, correction of hypomagnesemia, which we don't do in the field, prevention or treatment of seizures in pregnant patients with preeclampsia or eclampsia, which we sometimes do, but oftentimes we wind up transporting a patient that has that. Of course, it can be used to treat magnesium deficiencies, and it relaxes various smooth muscle tissues. An overdose of this, we wind up with a loss of deep tendon reflex, and that means that the patient is going downhill fast, and they need some calcium gluconate. Sodium bicarb is an alkalizing agent. IV push or added to IV fluids. Excessive administration can cause fluid volume overload, alkalosis, electrolyte abnormalities, cerebral and pulmonary edema. Thiamine, vitamin B, used to correct thiamine deficiency. We used to give this as our alcoholic cocktail, D50 and thiamine. Usually would get somebody right back to their self pretty quickly. Usually IV, unlikely toxic or have any adverse effects when therapeutic doses are administered. Not carrying a lot on the truck anymore. So that's just a quick rundown of a lot of the medications. That's chapter 13. Work on your drug cards. You're going to be needing those pretty quickly. So I would start on those pretty quickly, and it's okay that you don't understand everything about those drugs. It's okay that you're not going to be able to memorize everything about those drugs. What we want to do is we want to start you getting familiar with these drugs, the specific drugs and their uses and their indication, contraindications, dosages, and all those things, so that when we get to the point later on in the program where we start telling you, you've got to know this drug and you've got to know when to give it, it's not the first time that you've ever heard about that drug. It's not the first time that you've ever looked at it or studied it or tried to get familiar with it. You'll be more refreshing yourself then. So you'll probably hear us say this more times throughout the course, is trust the process. It may not feel perfectly normal to you right now, but just trust the process. It'll all work out. We'll get you there, all right? Good luck.